and he says a smoker, already you know that this is a blue butter. This is a pink puffer when you have small one. Okay, so keep this picture, it will help a lot. Okay, blue butter, there is a chronic bronchitis, typical the way they present. They are big, they are short of breath, and then they have a little bit of bluish tongue and cyanotic, as you see it. So with this picture, we will try to put our clinical symptoms straight away. Just looking at him, keep him in your mind. Okay, let's go. I will start with COPD. COPD is characterized by a persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airway and lungs to toxic particle or gases. Your gases is all your pollutant. And then the increase in production of the mucosa cause a mucous plaque that is typical in chronic bronchitis that obstrude the passage of airway, causing air trapping, leading to hypercapnia and hypoxemia. You will see that in chronic bronchitis, the problem is a mucus problem. Are you with me?
Yes, doctor.
Okay. For blue butter or chronic bronchitis, the problem is of mucus. There is a problem of mucus. Remember, in asthma, I also give a small illustration. The allergen, or here it's gonna be the smoke or the polluant get inside, the body does not stay quiet. It tries to take it out because most of the time it's too much of it and it's repetitive. You just keep on smoking, you just keep exposed. So at the beginning, the body will try to figure out what to do, will take it out. But as time goes by, it becomes a chronic process. And know that in asthma, it was reversible. But in COPD, it's irreversible. We are not going back. You can give your bronchodilator, we are not going back. You have damage. It means, comment on dit en français? Tu as atteint le seuil où le corps n'en peut plus. It have tried to balance, it have tried to restore. L'équilibre a été dépassé. Ça a essayé, mais tu as dépassé l'équilibre. That's why when they start smoking, they are okay. And as time goes by, the body can't make it anymore. So you have been smoking and smoking. It was 1 cigarette, now it's 10, now it's 20, for 20 years, for, I don't know, you change now, you are using the Oka pipe because they say there is water and water try, you still smoking. So your bronchus or your airway says, okay, what should we do? Remember the whole epithelium or in the airway is on appelle ça comment? C'est un épithélium stratifié cilié, si vous vous rappelez. Alors stratifié parce qu'avec différents niveaux, il y a différents basales, vous avez les cellules basales qui se renouvellent à chaque fois, and then vous avez les goblet cells au-dessus, si vous vous rappelez un peu de l'histopathologie, ils sont un peu gros avec un espace à l'intérieur pour garder les mucus, et au top, vous avez vraiment des cellules qui sont ciliées. Et les cils sont là grands, essayons de balayer tout ce qui est mauvais. But as time goes by, tous ces cils deviennent short, ils sont vraiment petits et les cellules deviennent hyperplasiées et hypertrophiques, grands et beaucoup. Essaient de se multiplier. Ces cellules sont dysfunctional. They are not working properly, although they are hyperplasic. There are many of them, but they are not working normally because of constant exposure to that polluant. So, les cellules, les goblet cells commencent à produire beaucoup de mucus. Leur capacité de storage est devenue tellement big que ça ne fait que produire. And as time goes, remember when you produce, il y a les macrophages, il y a les eosinophiles, il y a toutes ces cellules-là qui viennent essayer de phagocyter tout ce qui est comme... bon, c'est une partie de globules blancs, si je peux dire, les human systems that kick in. Essaye de phagocyter toutes ces histoires, essaye de les tuer, de les envoyer, de les expulser en dehors, mais it's just too much for the airway. What will happen? There is hypersecretion of mucus. And sometimes, at cause the globule blanc, those mucus can cause a plaque. And that plaque can sit anywhere in the airway. If it's in the big bronchus, when il y a un plaque, ça veut dire il y a réduction du diamètre à ce niveau-là. Ça veut dire l'air peut entrer, l'air peut sortir, mais il y a un peu diminution du calibre. Le diamètre est devenu un peu petit. Ça dépend du size du mucus plaque. So if it goes a little bit down, pas dans l'arbre, le gros bronchus, but it goes a bit down dans les bronchioles, dans les alvéoles, les plaques peuvent se faire n'importe où. Essayez de voir un peu si c'est une petite branche là en dessous et c'est là qu'il y a un gros plaque. Qu'est-ce qui va arriver? Et maintenant, ça ne tient pas seulement un seul alvéole, mais ça peut tenir 2, 3, 4, 5, même toute la base de l'alvéole. Même toute la base de l'alvéole peut être atteinte. Ce qui te fait une bonne partie où le lobe du poumon est atteint à cause de tout ce phénomène. That's what's going on in chronic bronchitis. So the problem is a mucus issue. You have a risk of pneumonia most of the time because of those plaques. Air trapping, mucus will be can get infected easily, and 2 pathogens have been identified in case of chronic bronchitis. It's your Haemophilus influenza and it's your Moraxella catarrhis. Let's go again. Yeah, this is your chronic bronchitis. Clinically, as a cough, productive cough occurring most days in 3 consecutive months over 2 consecutive years. So someone with a cough and say, doctor, when I cough out, the phlegm are greenish, you say chronic bronchitis. No, doctor, you will be wrong. You need to ask, it has been there for 3 consecutive months and over 2 years. So you're gonna treat it, small antibiotic, cough mixture, come again, it's still there. I feel a bit better. And then it is there. It means that person is still smoking or is still exposed. So it continue doing that. So after 2 years, you say this is no more acute, it's a chronic bronchitis. And when you say chronic bronchitis, you know that it's one of the main picture in COPD. So I passed by a question where they were asking, how can you define chronic bronchitis? So you have the answer, 3 consecutive months, over 2 years, it's a chronic bronchitis. Okay, causes, I think I'm talking more than what I'm writing. I told you the main cause is your cigarette smoking. Hookah pipe, cigarettes, which other things that you know? They will say other people, I even found also drug user, those who are sniffing heroin, mandrax, everything that they sneeze, it goes with them in chronic bronchitis or emphysema. So they end up having COPD. You will probably ask me, doctor, how? They say those things are not pure, but they are mixed with other things. So it's those residual things that constitute the drugs that make them to be sick. You have occupational exposure and recurrent bronchial infection leads to inflammation of the narrow airway and increase the mucus secretion, coupled with inhibition of the cilia, which leads to an accumulation of secretion, is what we say. So there is bronchoconstriction due to irritant receptor activation, which also cause a chronic productive cough. IV drug user, cocaine, methadone, heroin are at high risk of developing COPD. What happened? The explanation is there. Vascular damage induced by the insoluble failure in like cornstarch, cellulose, top, fiber, etc. Those things are mixed in the drugs. Risk of developing pneumonia due to Haemophilus influenza or Moraxella. And I will tell you, when you have these people, your first choice antibiotic will be azithromycin. And you know, azithromycin, you give 500 milligrams daily for 3 days or 5 days, but it's 3 days. It's a macrolide, and it has this anti-inflammatory effect, and is very effective on these bugs. Okay, that was your chronic bronchitis. Any question on chronic bronchitis?
Hi, doctor. Hello.
Yes.
Yeah, I want to know.
I can hear you.
Yes. Azithromycin is expensive in the market. Like someone who's not going to the, beside of azithromycin, we can use other macrolides, like which one by experience?
Erythromycin. But remember, erythromycin has a side effect of giving you diarrhea. So if your patient will not mind, go with erythromycin. It's a BD drugs, but it gives diarrhea. It really irritates your gastrointestinal.
Yeah, like if you give azithromycin, there's no improvement. How about combining like macrolide and Flagyl?
Flagyl is really not advised. Flagyl, you use it for gram-negative. So it means if you can take, because there can be underlying anything that keep those secretion. Remember, your patient can be COPD or chronic bronchitis and immune suppressed.
Okay.
So if the immunity suppressed, expect to have other bugs than these ones. It can have COPD and is a diabetic, remember?
Yeah.
So you will have other bugs. So macrolide is your first choice that you have to keep in mind. But as someone presented this Wednesday in our meeting, you can check other factor. It means if she's pregnant, you need to test something that's gonna suit the pregnancy. If she is immune suppressed and you make a blood culture, you need to choose an antibiotic that will suit that condition. If she's renal impaired, you can choose all those things, but have in mind that your first
azithromycin. Thank you.
Macrolide azithromycin will be the first.
Sorry, doctor, I have a question.
Yes, doctor.
What about amoxiclav? Can we use it?
You can use your amoxiclav. Remember, your patient will be diagnosed with chronic bronchitis after 3 months of consecutive cough over 2 years. So it means you are still waiting 2 years to say now it's chronic bronchitis. So in the meantime, our tendency is to say, if the patient says, doctor, I cough, and when I cough, there is a greenish or yellowish sputum, you put an antibiotic. And the cheaper one is your amoxil. Those people become resistant because over 2 years, all this time, the patient will consult you. You are giving something. And your first choice will be your amoxil. So it will say like, no, it's help. I was quiet for a little bit. It's come again. Then you say, okay, let me increase my antibiotic. You give amoxiclav. And then you go again, you say, okay, it didn't help. Okay, let me give my second or third generation cephalosporin. You go with your cefuroxime. You will be trying because the patient will be coming to you. When you give antibiotic, it's having some times of release, but the cough is there because he's still smoking or he's still exposed. You understand? So you're gonna give all those things, but for the sake of the exam, you really have to know what your literature says. Azithromycin will be the first. Oh, you can have a question where they give you which antibiotic will from the above a patient. They give you a small data and then they say which antibiotic will be your first choice. Then they put your macrolide, azithro. They put your augmentin with your co-amoxiclav. They put your cefiro. They're gonna give a session and then they say at the end, both of the above, choose the most probable or choose the most correct answer. What are you gonna do? You see, you find yourself in, this is not the time to be in our experience, what we are doing, but this is the time to stuck on the guideline, to stuck on what they say, what the evidence base says. So what I'm giving you is evidence based. Clinical, you're gonna find that this is expensive, but evidence base says your first choice is macrolide. Why? Because it's not only an antimicrobial, it also has an anti-inflammatory effect. Remember, we are using again azithromycin in our STI. 1 gram stat. Someone have read that. So we give Kefriaxone, IVI 250 IM, 1 gram stat azithromycin, and 2 gram stat flagyl for your discharge and for your STI. Doctor, could you again recheck all your microphone? Someone have to have his mic closed. Thank you. Any other question, or we can go to emphysema?
Hello, Doc.
Yes.
Yeah, I wanted to understand well. I didn't understand when you are talking about 3 consecutive months over 2 years.
Yes.
I wanted to understand if you have a patient who came for the first month with the cough, and after 1 month, he came again with the cough. After maybe 1 year, he's coming now again with the cough. Are you gonna put him like is a chronic or is not a chronic?
Okay, this is how you will go. You are asking me to go in, let's say you have a consultation, someone with a cough.
Yeah.
Remember, you will just see first a common cold, your flu, give you cough.
Yeah.
It's gonna take 10 days, it can develop in a bronchitis. That one is a acute bronchitis. That's gonna take one week or 10 to 14 days, 2 weeks, you're gonna also use a little bit of antibiotic, okay? So you have treated, it's gone. Remember in your cough, don't forget to open your OPQRS, onset, propagation, productive, loss of weight. A cough is a cough.
Yes.
Don't take away your TB, okay? And then after asking, you are going to examine your patient. Examination, inspection, auscultation, percussion, you have something you will say is a pneumonia, is a common flu, or I don't know, you will say it's something. You're gonna you're gonna manage. Yes, or you're gonna say no, with my loss of weight, or with my anorexia, with hemoptysis, I'm gonna also ask a gene expect. Okay, which gonna come, negative or positive, you know that is my TB.
Yes.
If it does not have anything it's negative, you says then it was just a cough. Then you're gonna send the patient, am I putting an antibiotic? There is fever, or you're gonna say, okay, I'm gonna hold the antibiotic because there is also what we call catarrh or running nose, rhinorrhea. So I think it's just a common cold. I'm not gonna put, I will just wait for the immune system to kick in. And then you say, no, it's persistent. The patient come again for review. You says, no, okay, I'm gonna do my ESR, CRP, or procalcitonin to see if there is an infection. Those things come very high. You says, no, it's a bacterial things because my inflammatory marker are very elevated. So what should I do? I'm going with a X-ray. Maybe your examination will say there are crepitation, there is everything. Don't forget, in your history, you also ask if, do you smoke? Do you work in a mine? Yes, I'm working in a gold mine. I am a painter. I am doing the painting. So you are smoking what? Did you see your question? Your lining of question will send you somewhere to go. So there will be remission. Your X-ray gives you a consolidation or nothing at all. The lungs are okay. So you have given your short course antibiotic 5-7 days. The patient says, oh, I feel better. The cough has subsided. Okay. It goes back again. Because where is going back? If he's a gold mine worker, rappelez-vous de tous vos pneumoconioses. Yeah, that's the name. Peinture, silica. I found also someone with emphysema, but he was working in a poultry. Juste enlever les plumes de chicken. Il a réagi. Alors, all your lining, and then because it's going to go back to work, so probably will come back again next month with a productive cough. Then you start thinking, you start again. Don't hesitate to check again the history. Retake again the history. Because maybe you may, either you or the patient didn't know that these things can cause, there is an irritant that is continuously irritating you. It can come again for the 3rd month. Then you have it consecutive month. But over 2 years, there is a period where it is doing that. Then you know that is a chronic bronchitis. I don't know if I have answered your question.
Thank you. I heard it. Thank you very much.
Try to open, to think out of the box. The patient won't come only with, I'm coming, you just look at him, you say, this is a chronic bronchitis. And I give you a picture of a chronic bronchitis. It's a blue bota. They are big. They have smoked for more than 20 years.
Yes.
You will be even laughing when you are saying, do you smoke? You will say, oh, doctor, don't touch that. I always smoke. But these days I've tried to reduce. Most of the time, they feel guilty and they don't want to feel attacked by you. They will say, these days I've reduced. I'm smoking only one. But it's not smoking. And remember, it has been there for 2 years. So the epithelioma in the bronchus airway have been dysfunctional already.
Okay.
Okay. Someone say, nous sommes sur un seul diapo dans le chat box. Je ne sais pas. Est-ce que tu me vois? Est-ce que you can share my screen? You can see?
Docteur, je vous vois. C'était au début. Au début, quand vous parliez de l'histologie. J'ai pensé que vous alliez peut-être mettre un autre. Diapo.
D'accord.
Excusez-moi, j'aimerais ajouter juste une petite phrase, docteur, parce que vous avez parlé d'autres causes de cough. Est-ce qu'on ne peut pas compléter la définition de chronique bronchitis en ajoutant, par exemple, après avoir exclu d'autres causes de tout?
Yes. Remember your chronic bronchitis. It's a bit long for you to diagnose it. You have your history, and then you have 3 months, consecutive 3 months after 2 years. So it means you have excluded. Then you are right. You can say 3 consecutive months over 2 years after excluding other things. Any other question on chronic bronchitis? We will take emphysema and then we will see what to do. I did share in the group something on gold pocket guideline. Did you receive it?
Which group, Doc?
Yeah, I put it in CODOSA Academic on Telegram, and I put it also on WhatsApp. If you see it, is your... Okay, it didn't come in. I'm gonna send
It's
again.
okay, group WhatsApp.
There is HPCSA exam preparation. It has 53 pages. If you don't see it, it's okay. It will probably come, you know. We have sometimes problem with connection.
It is in CODOSA Telegram.
HPCSA exam preparation, and you have it also in Telegram.
Yes.
Yes, it is.
Okay. When I will do the management, we will go with that one. I didn't want to put it on my slide, but we will try to go to management through this guideline. That's why I want you to have it so that everybody can follow. Okay, we will go to emphysema. Okay, emphysema is the second type of COPD after chronic bronchitis. So both two, chronic bronchitis, emphysema, they are irreversible, while asthma is reversible, number one. Number two, chronic bronchitis is a mucus issue, while emphysema will be a structural problem. Is the structure of the alveolar, of the bronchus, of the airway, the problem. What's going on with emphysema? Still the same cause. Your pollutant, your smoke, your whatever. And number two, second cause of emphysema is your alpha-1 antitrypsin problem. If there is alpha-1 antitrypsin deficiency, it's an autosomal disorder on the liver. You acquire it. So when you have someone who's have emphysema, is young, he never smoke, never work in a mine, then you have to check the liver and see if there is no alpha-1 antitrypsin deficiency. That is the second cause of your emphysema. Okay, so when you inhale, there is a phagocytosis that releases some cytokine. Those cytokines by the neutrophil are going to have secrete protease. Those proteases are non-specific or more specific. The more specific proteases, there are many. There are many proteases that have been secreted. Remember, as you have your histamine, your leukotriene, there are many, but this specific one is elastase. And the elastase will go and break all the elastin tissue around the structure of the alveolar or the airway. So, parce qu'on est en train de tuer ou de casser les tissus élastiques, your alveolar have to, when you inspire, you ingest your airway, it means ça gonfle. And then when you exhale, your elastin is going to squish so that you remove your CO2. Now the elastin have been break down. What happened? Your alveolar just become a big pocket like an air balloon. Try to remember when there is a birthday, you blow the balloons, leave them. If the kid does not burst them, leave them. After 3 days, what happened to them? Are they having the same size than when you were pumping them? No, they are loose, they are tired. That's what happened to the alveolar. They become a big balloon, so it becomes difficult for your chest to recoil because the elastin have been damaged. So it's not only at the level of the alveolar, it's also the whole bronchus. Wherever there is elastic tissue, it breaks down by these elastase. So that's what gives you emphysema. So you can see chronic bronchitis was a mucus issue, while emphysema is a structural problem. It's the structure. It's a structure. So what I can add again is it is not a cut-off. Ça, c'est un pure chronic bronchitis. This is a pure emphysema. No, these things can be like overlapping. They can overlap. Il y a un peu un touch of chronic bronchitis. Les mucoses sont excrétés massivement. Et il y a aussi l'élastane qu'on est en train de braquer, l'élastase qui est produite et qui est en train de couper. So they are overlapping. Et production de muqueuses et l'emphysema, l'élastane, et ça overlap. Those two things can overlap. So there is no a clear cut off. I can't tell you there is a clear cut off. This is pure, this is pure. No, those things can overlap. So in one patient, you can have both. But one will be more exacerbated. So, tu as un blue butter et un pink puffer dans one, mais l'un va se manifester plus. So, il a le 2, mais c'est plus l'emphysema qui se voit. Il a le 2, mais c'est plus le chronic bronchitis. So, it means il cough, il est bleu, il est cyanosé. Mais il y a aussi, quand tu regardes au niveau des alvéoles, il y a aussi le balloon qui se fait au niveau des alvéoles. So, you can have both two overlapping. So when I go back again to my slides, this is what I'm trying to explain. The walls of the alveoli are destroyed by enzyme called protease. These are usually kept under control by another group of enzymes called antiprotease. So do you see how God has created us? There is a balance. The proteases are there, but you also have the antiprotease. That's, there is an equilibrium going on. So when the balance is upset, destruction of the alveoli occur. It means too much protease than antiprotease, leading to a collapse of the airways, resulting in an obstruction. So air trapping will be there also. Let's see. Oh, okay. That was an empty slide. I'm going to talk again a bit about alpha-1 antitrypsin. It's a serine protease inhibitor secreted by the liver into the blood, which inhibit the enzyme. So neutrophil elastase from the damaging lungs tissue, deficiency of this alpha-1 antitrypsin leads to a unopposed elastolysis, destruction of the elastin fiber in the alveolar wall. That's what I try to explain. And there is an early emphysema that's gonna come. So it's a protease, antiprotease hypothesis of emphysema development. So when they say cause of emphysema, you know that first of all, emphysema is irreversible, and then is a structural issue. It could be by smoking, the neutrophil give the protease and more the elastase that go and destroy, and the body can't release a lot of anti-elastase one, so it destroyed the alveoli. Number 2, it's alpha-1 antitrypsin deficiency. So what will happen? There is a buildup of CO2, carbon monoxide, which is gonna lead to a hypercapnia, and the O2 is decreased. That will give the hypoxemia. But as I told you at the beginning, the oxygen will go and try to go, air trapping will come a little bit later on. So don't wonder if you do your blood gas, you have normal oxygen, but as time goes by, it will go low. And you start by having normal pressure in the CO2, and then it will go very high. On this slide, I just try to show a little bit. I know there are people who have a, as we call it, a photographic memory. When you see, you will never forget. So your chronic bronchitis is there, a healthy one, lumen here, and then when there is excess and hyperplasia and hypertrophic of goblet, this is how the lumen remain very narrow with a lot of secretion. And for your emphysema, you have, yes, doctor, is there any question? There is a question. Come again? Hello, doctor, I can't hear the question.
Blood sister.
Are we together? Oh, okay. I will continue then. This is your healthy alveolar. Those are the alveolar membrane that are breaking down, full of air trapping inside. The elastin is destroyed. They just become floppy, if I may say. Can everybody check again the microphone? I think there are doctors who are talking in between them. It's interfering with us. Check again your mic. Thank you. This is another picture. Normal bronchias, and this is the one that have air trapping, narrow, a lot of secretion of mucus going on, the elastin tissue. You can see even in the main bronchus, destroyed because of the pressures. The pressures are destroying completely. Look at the alveolar, that's how they become full of air with air trapping inside. They collapse sometimes. Okay, so talking, this is I try to make a summary of what I've been telling you about the two. Alpha-1 antitrypsin deficiency is a autosomal human disorder. And then you have your environmental insult, long-term smoking, pollution, infection that goes. So there is a decreased lung ability to prevent damage with antitrypsin. The balance have been not restored. And then for the polluants, you have the free radicals production in the lungs, inactivation of lung anti-protease. So the protease is gonna destroy especially the elastase. There is a lung inflammation, increased oxidative stress, inflammatory cytokines, and protease function. It's gonna progress. If it continue, injury to the bronchial tree, and this one will give you injury to your lung parenchyma. Inflammation of the cells by the neutrophil, the globlet cells gonna become hypertrophic and hyperplasic, too much production of mucus, death of the airway epithelioma, ciliated cells, so the cilia are not working properly, airway fibrosis and narrowing, mucus trapping, airway that can lead to infection, and it gives you chronic bronchitis. And on this side, decreased airway elasticity. So the recoil ability have been destroyed. Structural support of the airway patterns is no more good, so they are collapsing. Permanent enlargement of the alveoli. Trapping of air within the lungs. Airway narrowing and collapse. Hyperinflated lungs. and then bulla. Rupture of air sac in the lungs. Bulla, it's just a big pocket of air. When some are destroyed, can give you pneumothorax, but a big sac of air in the whole lung, it's a bulla. It can also rupture. So there is no lungs at all, and it gives you emphysema. All of them is your chronic obstructive pulmonary disease. Clinical finding and complication, that's gonna be our next slide. I think this physiopathology, from this physiopathology, you can also know the sign straight away. I think we will try to do that exercise. But before we go to the clinical future, I want to emphasize something. I think I didn't write. You have 3 types of emphysema, and the type are classified according to the parts of the lungs that are destroyed. So you're gonna have a central acina alveolar when is the proximal or upper zone of the lungs that are destroyed. So it's only on top. You call it central acina. You can have the second one, you say pan-acilar. It when is the lower zone of the lungs are destroyed. We call it also distal, the distal alveolar. So distal emphysema. And you have the third one, the one that conduces most of the time to bulla or pneumothorax. It's a distal acina emphysema. The distal one, it's the alveolar or the structure around, comment on appelle? Around the external cover of the lungs. It's the one that causes spontaneous pneumothorax. It's the one that gives you atelectasia of the lungs. It's the one that gives you lung collapse. C'est distal acina that are destroyed. So talking about that, all of them will eventually cause to a decreased perfusion because les alvéoles ne sont pas en bonne santé, ne sont pas bien. Alors les échanges au niveau des capillaires en bas là ne se font pas bien. Il y a plus d'accumulation de CO2 parce que ça ne sait pas sortir. And then, because il n'y a pas un bon échange, ça va se répercuter sur le cœur droit. If you can remember, le sang oxygéné passant par le poumon, quand ça rentre, c'est le cœur droit qui sera more affected. And your right lungs give you increased GVP. You have hepatomegaly because it's the right side of the lung. And it's gonna give you what you call cor pulmonale. Le cor pulmonale, c'est quoi encore en français?
Cœur pulmonaire.
Cœur pulmonaire.
Cœur pulmonaire.
Cœur ou corps pulmonaire?
Cœur
Cœur
pulmonaire.
Cor pulmonale. Yeah, it's gonna give you that increased pressure in the right. Ce phénomène aussi ne va pas s'arrêter là. Ça va se répercuter sur le cœur gauche. As time goes by. C'est comme ça que tu as ces COPD qui end up with congestive cardiac failure. Ça commence par le cœur droit, cœur gauche, et c'est tout le cœur qui est abîmé. So you're gonna have them, they can't breathe, they are short of breath, they have edema, and it's gonna be your first rule out. Is it really a COPD that gave me this CCF, congestive cardiac failure, or is it a congestive cardiac failure that is going to pulmonary edema? Did you see how this the symptoms can lie? If you don't take a good history, a good examination, you won't know which one have started. So your good clinical judgment will show you where we are going. And remember, people who are smoking are informed. They are aware because on each pack of cigarettes, they inform them what will happen. but they're just stubborn and they just enjoy the cigarette. So they know all those things. They won't even come to you when the cough starts. They will have a friend who will prescribe 1, 2, 3, spit out, you'll feel okay, When they start coming, you already have some level of cough pulmonary already starting. So we are in a stage where, yeah, we need to judge what are we gonna do. Okay, as time goes by, low ventilation, decreased perfusion, hypoxemia, vasoconstriction, increased pressure in all the branches. You have your pulmonary hypertension and right ventricular preload increase, which gonna lead to the right ventricular failure and your cough pulmonary. As I told you, with what I told you, you can see the symptom that will come. Increased GVP, hepatomegaly, edema will come. Those are the signs that come with your right. So clinical future of our COPD and chronic bronchitis, we will try to compare them. And remember now the picture that we put, pink puffer and blue butter will give us the symptoms. Any question about physiopathology before we go to symptoms? I did put a little bit of pathogenesis of emphysema, the 2 causes. Smoking is not only smokingness, put smoking and other polluants. And then you have alpha-1 antitrypsin deficiency. Okay, inflammatory cells, this is a beautiful globulate cells. Look at how small they are. As time goes by, it's just a big pocket. This is your epithelium, stratified epithelioma here. Basal, goblet, and then look at the cilia. As time goes back, they become short, they can't sweep nicely, they become sick. Mesenterial cell. So when there is secretion of cytokine protease, your ECM degradation, and then apoptosis, necrosis, alveolar parenchyma destruction. Those are the symptoms that I put. Je crois que tout le monde peut deviner avec la synthèse de mon physiopathologie que je vous ai donné. You can think of what's going on. Blue butter for CB. CB is your chronic bronchitis, and pink puffer for your emphysema. But it is not, there is no clear cut-off. Ça overlap. Ces 2 histoires, c'est overlap. Okay, so your blue butter will be obese, as you see, and they are cyanotic, the lips are cyanotic, while your pink puffer will be cachectic, weight loss. Il y a beaucoup d'énergie qu'il perd, c'est pourquoi il ne gagne pas le poids. I think someone went through, vous voyez quelqu'un qui ne respire pas, il est vraiment cachectique. Comme un marasmique, yeah, marasmus. And then number 2, dyspnea on exertion. All of them have dyspnea, short of breath. This side also there is some dyspnea, but you have to understand that the emphysematous person have to purse his lips for expiration. So il ferme un peu sa bouche et il exhale doucement. Il fait ça pour prolonger son time, to prolong the time of expiration. Il veut prolonger cela. Rappelez-vous, c'est un grand ballon plein d'air qui est là. Ça ne recolle pas. Ça ne, how should I put it? How should I say? It does not vasoconstrict by itself because the elastin muscles have been destroyed. So you have to purse his lips for him to exhale. So to prolong, ça l'aide un peu. C'est un mécanisme de compensation qu'il essaye de faire. Et c'est de là que l'énergie part et il perd le poids. Pendant que celui-ci, c'est seulement tousser, le plaque est là, some come out, the mucus produce again, another one come out. Number 3 here, productive cough. This one can have a cough, but it's more dyspneic. Little bit of cough, it can be there. And then this pink puffer have a good oxygenation at the beginning. So the oxygen can get in. When it has to come out, when the exchange has been made, that the problem starts. So with them at the back is more hypercapnia, that starts first. So oxygen can come in, but exhale is where the problem comes. Wheezes and growls, both of them. Très souvent, on pense que quand tu auscultes, il y a des crépitations, ça veut dire qu'il y a infection. Je dois mettre l'antibiotique. No, it's wrong. You need to justify your antibiotic. And if there is a big problem of resistance nowadays, it's because of us, healthcare workers. We are prescribing antibiotiques à tort et à travers. C'est comme ça qu'il y a des résistances. Vous savez qu'une étude a été faite, si vous le cherchez, et ici en Afrique du Sud, on a trouvé, je crois que c'est l'AMPAT, le laboratoire, le grand labo qui a fait cette étude, la période de COVID. On a trouvé que les malades qui sont morts avec le COVID, ils sont plus morts à cause des surinfections bactériennes. Pourquoi surinfection bactérienne n'a pas répondu aux antibiotiques? Ils étaient tous résistants aux antibiotiques. Ce qui fait qu'il y a des bactéries qui se sont développées très résistants. Tous les antibiotiques qu'on donnait ne répondaient pas. Pourquoi? Chaque malade qui est hey, mon frère, on m'a diagnostiqué positif, Zwakaka azithromycine. C'était l'azitro, c'était l'augmentin. Et rappelez-vous, on devait mettre encore le prénisolone pour dry up les langues. Ces malades sont morts avec les résistances aux antibiotiques. C'est induit par qui? Par nous, notre faute, les cliniciens. So even yourself, before you take antibiotic, ask yourself, did I really need it, or I'm just scared, or I want to, I don't know. I don't like medicine. I'm not someone who take just like that antibiotic. For what? Did you see that? So think, even when you are doing locums, you think you are helping them. But at the end of the day, c'est toi qui leur rends un mauvais service. They will be resistant. They will be resistant. Sometimes you give, you are not even sure that they're going to complete the course at all. So careful with your antibiotics. J'emphasize ça pour vous dire, tous les malades avec COPD, chronic bronchitis ou emphysème, ils ont des râles. Ça ne veut pas dire qu'il y a infection. Si tu as diagnostiqué COPD, tu vas avoir les râles. Pourquoi? Le air trapping là. Rappelez-vous, pour le chronic bronchitis, it's a mucus plug. So oxygen will come with a little bit of difficulty too, because there is a reduction in the diameter. And when the hair have to come back, it have to pass that plug. So it can give you that's your crepitation, that's your râle. So ce n'est pas vraiment une infection, c'est seulement mechanical. It's mechanical something. So you're gonna have that wet crepitation, the same as emphysema. Ça va te donner quelques râles. So tu vas me dire, doctor, how should we say it's an infection? Your marker, inflammatory marker, est le plus spécifique que d'habitude on néglige ou on ne fait pas dans le gouvernement. Procalcitonine. On fait le ISA, on fait le CRP. Et rappelle-toi, le CRP, c'est celui qui s'élève first and rapidement, et puis le ISA commence à venir parce qu'il prend le temps. Il est un peu en retard par le CRP. Le plus acute, c'est cela. Okay. And then to have the increase anteroposterior data. The COPD on the funny chest, barrel chest, I think, yeah, barrel chest. You're gonna learn it again when we will be doing together a chest X-ray. Rappelez-vous, chest X-ray, comment interpréter chest X-ray in ski. So on va voir ça parce que tu vas voir aussi le diamètre. Mais celui-là, tu peux le voir à l'inspection. Tu mets le malade, mon profile, tu vas voir vraiment, il a le barrel test. Ce sont des mécanismes compensatoires pour essayer de l'aider à breathe. Et rappelez-vous, l'élastan là, tout ce qu'on produit, les antiprolases, même le diaphragme, s'il y a il y a l'élastan, on le diaphragme, il est aussi inhibé, on les tue aussi, donc le diaphragme aussi ne réagit plus normalement. Il est aussi malade. Parce que le diaphragme t'aide aussi. Quand il inhale et exhale, le diaphragme aide, mais il est aussi atteint de la même maladie. Hyperrésonance, percussion, tout le dos de résonance. Diagnosis workup. OK, dans ton diagnostic workup, c'est l'histoire. History taking, complément d'anamnèse, n'oublie pas de regarder. Where do you work? Vous avez fait, je crois que you went through when you were doing consultation with Willow. Doctor, close your microphone, please. Doctor, can you have your mic closed, please? Thank you. History taking, we are clear. You have done that in consultation. Acute or chronic consultation, you have done that. So your history, gonna be fun. You have again your pulmonary function test, FEV1, forced expiratory volume in 1 second, and forced vital capacity, FVC. All of them will be reduced. And the ratio, remember in asthma, someone can remember? The ratio of FEV1 over FVC.
Less than 70%.
Thank you. Vous m'encouragez. Less than 70%, ça te dit qu'il y a obstruction of the airway. Et puis, tu fais 20 minutes avec your SABA, tu vas voir que ça va augmenter. Maintenant, ici, ça veut dire you're gonna have it also less than 75%. It means there is obstruction. What next? You're gonna do your SABA, and then you repeat. It's gonna be above 12% increase, then it's asthma. This side is not gonna increase. It's gonna increase of 6%, not above 12%. It's your COPD, chronic bronchitis of emphysema. Is it clear? You're gonna have your pulse oximeter that you're gonna put to check saturation en oxygène. Très souvent, ce n'est pas 100%, ce n'est pas 99%, something below 95%. Tu commences à regarder, what am I dealing? Sometimes when they come very dyspneic, you have it around 85%. But you need to know that because when it's less than 88%, that patient needs supplementation on oxygen. Mais non, quand tu donnes l'oxygène, tu donnes combien? D'habitude, on donne beaucoup. En une fois, tu veux voir la saturation à 100%. Once you know that is a COPD, forget about 100%. 92% it's okay for you. That patient is okay. 92, 90, it's fine. Leave it like that. When you put too much oxygen, you're gonna remove that hypoxic drive. They are used to be hypercapnic. So don't give a lot. You're gonna use your non-rebreathing mask because you don't want to give a lot. You're gonna use your Venturi mask. 2 liters is okay. So when the oxygen is 90% and above, with signs of right ventricular failure, you need to give again oxygen supplementation. But if there is no sign of right failure, 90% is okay with that patient. You're gonna do your ABGs. You know that ABG will gonna give you a respiratory acidosis with your pH low, PCO2 elevated, PO2 low. We just confirm. You will do your ECG. Why? You are ruling out. You have to rule out, am I having a MI? Very diffuse MI that give me failure. Am I having a congestive cardiac failure? Am I having a atrial tachycardia? Atrial tachycardia that can go to fibrillation when the heart is not pumping while it's doing this. How are you gonna perfuse? You're gonna be like short of breath. You're gonna feel like you are suffocating, like you are dying. So ECG is gonna make you to rule out what's going on. You're gonna have your chest X-ray. Is there any pneumonia coming? Is there something else? Is it a huge pleural effusion? Is it a pneumothorax? Is it chest X-ray to rule out what you are having? Is it Ebola? Pneumothorax, you need to put your ICD. We also go to CT chest. Remember your pulmonary embolism, D-dimer, that blood need to be taken. Take all those things to check what you are having. Even for you to start your antibiotic, you're gonna need blood, your WBC. We're gonna go to treatment. Any question before we go to treatment? Ça passe ou ça casse?
Ça passe.
Ça passe.
Doc.
Ça devient, même,
Mm,
ça devient même facile. Hein?
ouais. Sorry, Doc, I want to know. There is a test. Je crois qu'on appelle ça spirométrie, hein? Hein? Pour différencier le COPD là, de l'asthme. Il y a même des rapports là qu'on fait de vital capacity.
C'est ce que moi j'appelle lung function test.
Yeah.
La spirométrie Gaussian.
Yeah. Si vous pouvez
pulmonary function test is your spirometry.
Yeah, si vous pouvez penser à organiser comment nous expliquer l'interprétation.
De la spirométrie, c'est au ski. Donc, on va prendre ça dans au ski. Comme on a parlé la fois passée, dès que nous avons, comme on a eu asthme et COPD, il y a des osquis qui sont attachés. C'est mieux qu'on fasse déjà les osquis attachés. J'avais compté 5, si je me rappelle. Tu as le peak flow, tu as le ADS, et tu peux faire déjà l'interprétation du test X-ray. Ils sont les osquis attachés à problème de poumon. Alors, il faut organiser, il faut qu'on ait quelqu'un qui est free aussi, qui va dire que je veux prendre. J'avais un candidat qui voulait bien, mais on va encore négocier pour voir. Rappelez-vous, you have to prepare yourself. You have to make a PowerPoint. You need to have time. We are not reading in one book. We are trying to go in many books as possible because your writing exam is not only South African guideline, it's all over. Your Med Manual, your Cécile, your, je ne sais pas, tous les livres que vous utilisez. J'ai un soin, sans soin ici, j'ai un moutag. Tu as tout ce livre-là pour l'examen écrit. Au ski, tu vas rester dans le Green South African Book. Alors, le docteur doit avoir le temps, un peu nous faire ces oskis rapidement. On va juste parler au docteur Tiswaka qui organise et au chef, si on peut avoir ces oskis. But you need also to make a request, a formal request on the group. Please, président ou organisateur, may we have this. Someone who want to do that can do them very fast. You need to have time. You need to give you 2 hours.
D'accord. Merci.
Merci. Nous allons passer au traitement. Premier traitement à ne pas oublier, je suis en train d'ouvrir le Gold Guideline pour qu'on aille avant. Je n'ai pas fait beaucoup de commentaires parce que c'est vraiment clair dans le Gold Guideline. Premièrement, smoking cessation. C'est un OSCI. Voilà un autre OSCI qui vient de s'ajouter. Behavior change. You have to do the behavior change et commencer avec le smoking cessation. Si vous ne pouvez pas, même quand vous voyez les malades, try. If you have read your behavior change, try to categorize your patient. Is he pre-contemplative? Is he contemplative? Did he put the action already? Did he try? Did he relapse? Are you back in contemplative? Rappelez-vous des A et des C, les cas down. Is anyone annoying you? Are you feeling, vous connaissez ces histoires-là? Behavior change. So start, at least put something, even in your consultation. Try to see this patient is well. Is it, if it's in pre-contemplative, you know the treatment, give information. Give information. He has a plan, try to check if it's realistic, achievable, you know those things. So it's another OSCI, behavior change. Number 2, vaccination. Quels sont les vaccins que vous pensez qu'on peut donner dans ce cas? Les gens qui sont chronic bronchitis emphysema. On a parlé. Thank you. Thank you. Number 1, influenza. Il faut les vacciner contre l'influenza. Number 2, pneumococcal. Pneumococcal. You have to give it. Parce que s'il vient faire une pneumonie avec ça, ça va les emporter. Alors, il faut les vacciner pour que le body soit vraiment strong pour fight. Number 3, in your treatment, think of supplementation in oxygen. C'est vraiment notre last resource. Parce que that patient need to be for 15 hours. Une journée à 24 heures. Lui doit avoir 15 hours on oxygen every day. So, ce sont ces papas-là qui sont stubborn, ils ne veulent même pas écouter. Quand tu commences, ils disent, I know. So 15 hours on oxygen. It's a low dose oxygen, but he needs to keep himself on 15 hours. So vraiment, c'est une grande décision à prendre que tu vas rester sous oxygénothérapie à la maison. As I told you, 88%, you start motivating or heart failure sign, what you call polycythemia. L'hématocrite est très élevé. Vous savez que les COPD et les COPD patients ont hémoglobine très élevée, 19, 20, 22. Donc, tu fais le HB, on te dit 22, tu te dis, le labo a de problèmes, est-ce qu'il y a un nouveau technicien? Ce sont ces gens-là. L'organisme essaie de produire beaucoup pour transporter beaucoup d'oxygène pendant que le problème est au poumon, là. Donc, s'ils sont aussi polycythémiques, il faut penser à supplémentation en oxygène. And comme vous savez, no high dose oxygen, don't remove the hypoxemic drive that is in the brain. And then we're going to go to your bronchodilators. Here also you have bronchodilators. Avec l'asthme, c'était ton SAMA, SABA, pas SAMA. Are you with me? So here c'est SAMA, South African Medical Association. SAMA. And SAMA stand for, le premier choix avec le chronique, le COPD, c'est your anticholinergic, les muscarinic antagonistes. So, short acting muscarinic antagonist, SAMA. Number 2, LAMA, long-acting muscarinic antagonist. LABA vient de là, du SABA, long-acting bêta-2 agoniste. Tu vas voir que le SABA a été enlevé, short-acting bêta-2 agoniste. Mais très souvent, quand le malade vient, on commence par ça, le temps d'avoir tout, then you know that it's your SAMA and your LABA that you are going to use. So, your SAMA is your iprapropium. Your LAMA is your tiopropium. So, for le muscarinic antagoniste, ils finissent avec les pium. Pendant que le bêta-2 agoniste avait les ol à la fin. Pas le paracétamol, on avait dit ça, mais les ol, le salbutamol. And then your SABA avait les salbuterol, salbutamol. But les muscariniques, c'est les pium, iprapropium, tiopropium. Maintenant, avant de les initier aussi, you need to classify. Mild or intermittent. Mais très souvent, on parle toujours de l'acute exacerbation parce qu'ils sont là, ils sont stables. Something happened, il vient, je ne peux pas respirer. So there is an acute exacerbation. What could have caused this acute flare, acute exacerbation? And then, tu vas commencer avec ton SAMA. Tu nebulises, tu check, is it becoming okay? Tu peux ajouter ton SABA, but every them are nebulizer or MDI. Si ça ne répond pas, you are going to moderate or severe. You're going to keep your LAMA and your LABA. Ça, c'est ton premier, your first line. And then, what should we do? Second line, your steroids. Your steroids are not low dose inhaled corticosteroids. You go already to patent 1, medium or high patent corticosteroids. We put them on your acute exacerbation. Your steroids finissent avec un on, prednisone, hydrocortisone. Il y a d'autres qui utilisent le médrol. Qu'est-ce qui est dans le dépôt médrol? C'est aussi un long-acting. Bêta-méthazone injection. Yeah. Ce sont les long-acting, if possible. So, tu as ton LAMA, your SABA, tu mets les stéroïdes inhale ou NEPS at home. Et dans ce groupe, dans ces cas ici, nous avons aussi other options qu'on met. Ce sont des phosphodiesterase inhibitors. Et le phosphodiesterase inhibitor, c'est là que ta théophiline vient. Et tu as la théophiline sirop comme solphiline. Even you, non, SCC, ce n'est pas théophiline. Et tu as aussi la théophiline IVI que nous donnons. Et il ne faut pas oublier, ils ont des side effects sur le cœur. Alors, quand tu as commencé à infuser, on dit toujours qu'il faut aller doucement et il faut regarder ton ECG trace if il n'y aura pas un prolong P-wave parce que ça va faire des histoires sur le cœur. When you give IVI, ça ne va pas seulement break down les cycles MP sur le muscle qui sont sur le poumon, mais c'est tous les muscles du corps entier qui a ces récepteurs. Ils s'attachent. So, si le cœur a ses récepteurs, il s'attache et te donne des effets cardiaques dont tu ne cherchais pas. Il y a un autre phosphodiesterase qui est spécifique. C'est le roflumaste. C'est un phosphodiesterase faux I. Il est spécifique, mais il coûte cher. Je ne l'ai pas encore vu de toutes les années dont je travaille. Number 4 is your antibiotic. Long-term antibiotic is not advisable, but as we say something about the antibiotic, macrolide will be your first choice. Pour savoir comment les combiner, you have your gold guideline, pocket guideline. Il te donne une bonne classification en fonction du FEV1 pour te dire, tu as 4 groupes, tu as les mild, tu as les modérés, tu as les severe et tu as les very severe from page 11. Et selon chaque cas, tu sais comment est-ce que tu vas commencer le traitement et comment est-ce que tu vas les combiner. Method-dose inhaler et nebulizer are preferred au first. Et ça, c'est quelle page? Page 16 of the guideline give you tout le nom. Inhaler, nebulizer, oral, mode d'action. Ça te donne tout ça sur page 16 et on te dit comment les mettre. Saying that, I will say I am done with my COPD. Any question?
Hello, doctor.
Yes.
Yeah, but when I check in the pocket guideline, it seems like they are still suggesting to use ISABA.
It is not a clear cut off, as I told you, doctor. You are not going to take it completely. And then check when are they saying we are using the SABA. At the beginning, when you put SAMA, you can put your SABA.
Okay.
But you're gonna see with them, it's the anticholinergic that are the first one. It is not alone. You can't just count on your SABA alone. It's gonna have an underlying SAMA. It means an anti-muscarinic, and that comes from your physiopathology.
Thank you.
When I was reading in mild and intermittent, they say put SAMA plus SABA, nebulize with those two, and then add LAMA or LABA if it's not improving. So it means you're gonna start and then you're gonna see that patient in 1 hour, you know how you continue. Ok, je vais laisser que vous lisiez et que vous cherchez, vous deviez asseoir les idées clairement parce qu'on ne sait pas les questions viendront d'où, but you need to know how to settle. Ceux qui ont, comment on appelle, blueprint, qui ont des anciennes questions, it was supposed to be good to have those questions and on essaye de les répondre ensemble. Oh, I like this blue butter and the pink puffer on. Any other question?
Yes, hello, Doc.
Yes.
I have a question about the supplementation in oxygen.
Yes, doctor.
You said when the saturation drops below 90, the patient should be given oxygen. And if it can be up to 90 or 92, it is enough. But in treatment, you said that the patient should be on oxygen for 15 hours.
Per day.
Yeah, per day. So even if after 7 hours, the oxygen is at like 90, 92, we should continue, or can you say more about it?
Okay, okay. This is what you do. If the patient, despite your LABA, your SABA, your everything, the saturation is only 88%. Let me reassure you, with a saturation of 88%, you are short of breath. Okay, so we can't leave you, we need to alleviate you. So wherever you do, wherever management, wherever treatment, the saturation is only 88%. You need to implement oxygen. It's not in the hospital, it's at domicile now. You have to keep oxygen at home. And there are many sort of small machine with oxygen. You will see people in the mall on a wheelchair with a bag with oxygen and a nasal prong. It's because when you start oxygen at home, it means you have to have 15 hours on oxygen per day. So you're gonna choose your 15 hours. Removing time where you are sleeping. If you want, you put it when you are sleeping. If you want, you have to put it at home. You have to put it during the day, but 15 hours per day, you need to be on oxygen low dose so that you mustn't leave negative things. Actually, something will happen. That hypercapnia can kill you. It will induce a severe metabolic acidosis and the body cannot just cope with that, and then you have a arrest. You understand? Number two, 90%, if you keep 90% saturation, but you have signs of congestive cardiac failure, right heart failure, that patient gonna need oxygen at home. It's not our patient in the hospital forever, no. At home, it means your LABA, your SABA, your phosphodiesterase is having all those things, plus your theophylline or your carbocysteine for production of cough at home, plus oxygen, because there are signs of cardiac failure. And when there is sign of cardiac failure, just try to give him supplementation on oxygen. Remember, there are balloons down there. The exchange are not good. So he can't breathe by himself. The diaphragm is not even working properly and he exhale by himself. He needs oxygen supplementation.
Okay, thank you, Doc.
You're welcome.
Hello, Doc.
Yes.
Just a small short question maybe for wrapping up.
Yes, doctor.
Is it relevant to talk about chest physiotherapy in COPD?
Physiotherapy?
Yes.
Very, very relevant. Dr. Alain Saman, I've seen your hand. I don't know if you were talking. I was just focused on my sharing screen, but now I can see hand raised. I will take you immediately after. It's very important. Remember, you have mucus plug. So sometimes those mucus plug can need to be a little bit, when you do physio, you nebulize with saline, you can dislodge some of them. So we do it, but you will see that although you are doing it, the patient is still congested, is still obstructed. So yeah, it's nice to do that. You have to do that. Sucking, you suction and then physio sucks. You're gonna have a lot of mucus. You can even send them also for your MCNS. They will tell us if they are just clear or if there is a bugs already for your antibiotic, if it's resistant, or you can even do your gene expect.
Thank you very much, Doctor.
Dr. Halle?
I didn't raise my hand. I don't know what happened.
Oh,
maybe it's a mistake. Sorry, Doc. Yeah.
Okay, okay. No, it's fine. Is there any other hand raised? J'avais une question que j'ai trouvée, mais je ne sais pas comment agrandir ça. Je dois d'abord tourner ça pour agrandir. Mais je veux mettre la question sous le groupe. Vous allez seulement vous exercer et je veux mettre les assertions. Comment est-ce que on a posé ça? C'est petit, j'ai essayé d'agrandir, mais c'est petit. Chacun va faire cet exercice sur lui-même avant de dormir ou when you think you can. Let me see if I can put you on CODOSA Academy. Ok, c'est petit, mais c'est comme ça que je n'ai même pas pu mettre ça sous mes slides parce que moi-même j'ai des difficultés à lire ça. Ok, j'ai mis la question et j'ai mis les assertions. Quelqu'un peut essayer de s'entraîner un peu avec ça. J'ai mis aussi l'autre. Saying that, on va toujours aider, on sera toujours là pour continuer, mais je sais qu'il y aura un stimuli qui va s'activer dès qu'on donne les noms. Dès qu'on donne les noms, je sais, from gear 1 of speed, on va aller au gear 5. Et le fait là que tu as reçu la lettre, que tu passes les examens, it gives you a drive that, I don't know, is it a dopaminergic drive or I don't know, but I think that time we will continue again. So I am done. I will say good night unless there is a question. Quelqu'un peut lire la question qu'on a ensemble, que je donne, qu'on voit un peu ce qu'on peut dire. C'est petit, je n'ai pas pu agrandir parce que j'ai pris ça de... Est-ce que ça ne sait pas? I think it came from diploma. Diploma in emergency medicine, something like that, yeah. Vous avez Telegram? J'ai mis ça sous Telegram.
Et on peut voir la question, c'est vrai, c'est petit, mais on peut zoomer un peu et puis lire.
Quelqu'un peut lire comme ça, on fait ça, ça ne va pas nous prendre 5 minutes. Vous allez voir que ça va sauter au cerveau directement.
A 65-year-old man complains of 2 years of persistent cough. He says that he coughs up with a whitish sputum almost every morning on waking, and then continues coughing throughout the day. He also complains of exhaustional shortness of breath that becomes disabling if he gets an upper respiratory infection. He has smoked 1 pack of cigarettes daily for the past 40 years. Pulmonary function testing reveals a vital capacity that is 65% of his predicted. Which of the following best explains this finding? So the following is A, alveolar capillary membrane thickening 88%, B, decreased functional residual capacity 7%, C, air trapping during expiration 69%, D, decreased lung distensibility 12%, E, respiratory muscle fatigue 1%.
What do you think, Dr. Patrick, your answer?
I have to get back to the question so that I can try to think again more about which answer to take.
Quelqu'un a
Maybe,
suivi la
yeah.
question? You can try while Dr. Patrick is thinking. Quelqu'un d'autre a relu encore rapidement la question et les assertions?
Yeah, I would choose B.
Okay, decrease functional residual capacity. 7% of residual capacity. Why, doctor?
Yeah, because in the question it states that the vital function is decreased.
VFC, force vital capacity is decreased, ne?
Yes.
But B says functional residual capacity and force vital capacity. Do you think they are the same? Residual capacity and force vital capacity. I think there is a little bit of confusion.
They are not the same.
They are. Did you see? The one that is decreased in the question if FVC, not residual capacity, which is going to be FRC. You're going to have all this term and nicely explained on your spirometry. But they are not the same. So assertion B is not going to be the answer for me. Someone else?
I'll choose A. I will choose A, Doc.
Okay. Explain. Explain, doctor. Your A says alveolar capillary membrane thickening. They are thick, maybe because of the inflammation, thick at 80%. In the question, where do you think this patient fall? Blue butter or pink puffer?
I think he's a pink. Is a pink.
Is it a chronic bronchitis? Is it an emphysema? The way
I can see, the patient is developing an emphysema.
Is developing an emphysema, but with productive cough over 2 months.
Blue butter.
A blue butter. You are having a chronic bronchitis which is going to emphysema. Yes, it's a blue butter, this man.
Yeah.
The blue butter. You have a typical definition of your chronic bronchitis in the question.
Yeah. Very clear.
Okay, I'm gonna leave this question. Think and justify yourself. We're gonna, when everybody will try, we'll go through the reading, you're gonna have the answer, because I think the answer is in your physiopathology. If tu as bien suivi physiopathology, the summary of the physiopathology, I think you're gonna have your answer. Let me see here on the answers if someone, in the chat, if someone says something. One message. Oh, dopaminergic drive. OK, let's go to the second question. But vous avez une idée de comment est-ce que les questions peuvent venir pour le COPD. Donc, il faut vraiment asseoir ces histoires, tout comme on peut jouer sous le LABA et LAMA. C'est blue butter de 65 years old men. La deuxième question. Quelqu'un peut lire et nous donner les assertions?
A 65-year-old man with chronic obstructive pulmonary disease comes to the emergency department with increased dyspnea and worsening cough for the last 2 days. He has been unable to rest due to increased symptoms. The patient has increased sputum production compared to his baseline. He tried 3 nebulizer treatment with albuterol and ipratropium bromide at home with no relief. His most recent spirometry during an office visit a month ago showed FEV1 at 60% of predicted. His temperature is 37.2. Blood pressure is 150/90. Pulse is 110, and respiration are 23. The patient oxygen saturation is 87. On room air, he appear to be in mild respiratory distress. Lung examination shows bilateral wheezing and prolonged expiration. ECG shows sinus tachycardia. Chest X-ray reveals a flattened diaphragm and no infiltrates. Initial laboratory studies shows a white blood cell count of 11,000. He started on supplemental oxygen, bronchodilators, and glucocorticosteroid. Which of the following additional therapies would also benefit this patient in the setting?
Thank you, doctor. Clear again. Il faut lire aussi les assertions.
Okay. A. Antibiotics. B. Chest physiotherapy. C. Fluticasone inhaler. D. Magnesium sulfate. E. No additional therapy. F. Rofimilast.
Roflumast.
Yeah, Roflumast.
Roflumast, c'est un, I think, le spécifique phosphodiesterase. Si j'ai dit, oh, je vous donne déjà les réponses. Analysons la question. Thank you, doctor. Analysons la question. Vous voyez que si tu es superficiel, tout ce qui est écrit là, on a vu ça. Mais quoi mettre où? Everything that was in the question, it is in the presentation, everything. But what is what before? OK, j'ai besoin de volontaires.
Bon, je pense, premièrement, il faut d'abord poser les diagnostics, savoir de quoi souffre ce malade ici. Et par la suite, on va savoir quelle prise en charge qu'il faudrait.
Et quel est votre diagnostic?
Cette fois-ci, je pense que ce malade, il est en train de nous développer de l'emphysème. Parce que quelque part là, on dit...
Je crois qu'il a déjà développé. Mais quand il se présente, avec quelque chose. Tu appelles ça comment? An acute exacerbation of a COPD. C'est un COPD patient. Mais il est venu ou il a essayé lui-même ses médicaments à la maison, ça ne marche pas. Alors, that's an acute exacerbation. A COPD stable at home, but this night, he came to the emergency department for an acute exacerbation. Now you need to find why. Why are we having an acute exacerbation? And the doctor tried to go with everything. Step 1, step 2, step 3. Now the question is, what is the step 4? That's what the question says. And you have the answer in what the doctor found. What did they find on the chest x-ray? Found something. What did he find on the white cells count? He found something. On clinical examination, he found something. So what is the cause of that acute exacerbation? It is in there. Now take the assertion. Take one of the answers. Is it A? Is it B? Is it C? Is it D? Is it E? Is it F? Moi, je peux même ajouter encore beaucoup de questions ici. On t'a dit qu'il a essayé à la maison avec... he tried nebulizer treatment with albuterol. Albuterol is a... Albuterol is a... Saba, Sama, Laba, Lama.
Is a laba.
Albuterol.
Laba.
It's a laba.
Albuterol is a laba.
Are you sure albuterol is a laba? No.
It finishes with all. What is it?
All.
Yes.
Albuterol goes in your Saba. They are two.
Yes, a Saba, sorry, not a laba.
Not laba. They are two. Yes. Vantolin, which is your salbutamol, and albuterol. Only two, yes, brothers.
It's a Saba, okay. Sorry.
And then he tried iprapropium bromide. What is iprapropium?
The Sama.
It's a Sama.
South Africa Medical Association, thank you.
Sama.
Vous voyez comment est-ce que vous devez faire l'exercice d'abord vous-même. Catégoriser ces histoires. Ça doit être au bout de doigt. So, il a pris un Saba. Donc, on lui avait déjà donné un Saba à la maison. Il a pris aussi un Sama. Ça n'a pas répondu. Ça n'a pas répondu. On te dit, lorsqu'il était à l'OPD, il avait déjà le ratio FEV1 over FVC less de 65, si je ne me trompe pas.
60%.
60%. L'autre, quand il était... Donc, vous voyez que c'est un COPD. Lui, là, il est déjà un COPD. Maintenant, quand il vient, regardez un peu sa température. Qu'est-ce que vous dites à propos de sa température?
37.2.
Yeah, we are going to a fever. Je
Yes.
prends ça comme ça. Regardez son blood pressure, normal ou abnormal.
Abnormal.
Thank you. C'est élevé. Regardez le pulse. Normal, abnormal.
110. Elevated.
Abnormal.
Cette fièvre-là qui a commencé, on peut lui donner ce pulse rate. Regardez respiration rate. 23 chez un adulte. Au repos. C'est élevé. C'est élevé. Vous voyez qu'il a un mécanisme qui ne va pas. Maintenant, on va encore. Chest X-ray reveal a flattened diaphragm. Ça, c'est pour vous embrouiller. Mais si on peut dire comment est le diaphragme, il est flattened. Rappelez-vous, l'élastane a déjà aussi été détruit. Si le diaphragme est bas, ça veut dire qu'il y a hyper-infiltration of... Les langues sont super inflées. Ce sont des longues langues d'emphysémateux. Donc, ils ont seulement expliqué quelque chose pour un peu vous. And no infiltrate. Initial laboratory study show a white cells count elevated, normal or abnormal?
Elevated.
C'est élevé. Les globules blancs sont élevés. On a commencé sur oxygène, supplementation, bronchodilator et aussi ils ont ajouté un corticostéroïde. Ça veut dire ils ont quitté mild to intermittent, moderate to severe. C'est là où ils sont parce qu'ils ont ajouté même les stéroïdes, mais ils ne nous ont pas dit lequel. Maintenant, quel est le prochain step que tu ajoutes?
Antibiotique.
Antibiotique.
Et pourquoi vous m'avez fait prendre beaucoup de temps comme ça pour me dire seulement l'assertion A?
Donc, par mistake, j'avais répondu A à la deuxième question, si vous vous rappelez.
Tu avais dit A.
Oui,
Au
quand on avait
pifomètre.
posé la question, quand on avait posé la question, moi j'avais répondu à la deuxième question, alors qu'il y avait deux questions déjà.
Question A. A, c'est la bonne question. Ce monsieur a une acute exacerbation avec une superimpose antibiotique. Si on continue, on vous dit quel est l'antibiotique que vous allez utiliser.
Azithromycin.
Ah, thank you. On ne vous donne rien, on ne dit pas qu'il n'a pas ceci, là, c'est là, il n'y a pas de contre-indication. Mettez l'azitro. Nous allons voir un peu les assertions aussi pour voir qu'est-ce qui peut nous troubler. Antibiotiques, oui. Regardez, chest physio. On vient de parler de
In the acute setting, yes or no?
fluticasole inhala. Qu'est-ce que c'est?
Un corticoïde.
Low patent. Le fluticasole va dans l'asthme. Quand on commence à introduire les corticoïdes, c'est le premier qui va là-bas. Si c'est low patent. Magnesium sulfate, Osway.
Asthma.
Asthma, compliqué.
Tout essayé, ton magnésium vient. No additional therapy. Là, tu te dis, ah, c'est un COPD, laissez-le sur oxygène. And then, roflumilast, c'est un phosphodiesterase que tu peux mettre. Si on n'avait pas mis les infections, la température, le white cell count, on ne nous avait pas donné le Q et l'inflammation. C'est le F qu'on allait prendre. Parce que ça, c'est notre drap qu'on pouvait mettre. Mais comme il nous a donné qu'il y avait une infection, je pense vraiment que l'infection, c'est le A.
Il y a l'antibiotique prime.
C'est l'antibiotique parce qu'il y a une infection. C'est l'infection qui a causé qu'il est parti, qu'il a déséquilibré actuellement.
Yes.
Bon. Vous avez une idée de comment est-ce que les questions d'asthme et de COPD arrivent? Il est 22 heures. Je vais laisser les gens se reposer. If there is no other question, thank you for your time. Thank you for listening to me. Thank you for your trust.
Donc,
Merci beaucoup, docteur.
Oui.
Question one.
Donnez-moi la réponse, docteur. J'attends la réponse. Qu'est-ce que tu en penses? Celui qui saute à monter, c'est l'assertion C. Il y a air trapping.
OK.
Mais si air trapping, c'est-à-dire c'est une emphysème.
Asthma, air trapping. Chronic bronchitis, air trapping. Emphysema, air trapping. Tous te donnent air trapping. So, il ne faut pas dire s'il y a air trapping, c'est seulement l'emphysema. Tout le monde fait air trap. Tout le monde. Air trapping, ça veut dire seulement c'est entré, c'est pas sorti. Ou ça sort doucement parce que le plaque est gros, ou ça ne sort pas parce qu'il y a vraiment vasoconstriction sévère. Ou, tu vois, vous comprenez un peu comment je vois les air trapping.
Yes.
L'air ne sait vraiment pas sortir. Parce qu'il n'y a vraiment pas d'élastane pour recoil ce chest et qu'on enlève le air. Il n'a pas qui. Ça fait un air trapping.
Yes.
Thank you, Doc.
Other question. Il y a beaucoup de questions. Il y a beaucoup de questions. Il faut seulement s'asseoir, commencer à les prendre et à commencer à vous les lancer. Même dans les battes que vous avez. Ceux qui ont des battes sur l'ordinateur, c'est bon. Il suffit d'écrire asthme ou COPD. Toutes les questions avec asthme ou COPD dedans vont sortir. Mais si vous devez aller page par page, cherchez tout ça et mettez. Ah oui, docteur, je veux mettre la présentation. Juste enlever, j'ai vu 2 ou 3 slides qui n'ont rien au-dessus. Je vais les enlever et puis je mets ça sur Telegram. Okay, if we are done tonight, le temps de dopamine drive, ce temps-là, je l'aime beaucoup parce que you have to distress. You have to distress. On doit simuler l'examen à 2 fois, 3 fois, 4 fois quand tu arrives à l'examen au Talangolobi. Si j'ai déjà eu peur, je n'aurai plus peur. Tu vas parler à l'aise. C'est tout ce qu'on fait. Lire, vous avez déjà lu. Mais il y a la peur qui vient inhiber. The fear. It's the fear that makes us fail. It's not that you don't know. Tu as tellement peur que tu deviens blanc. Tout s'efface dans la tête. Alors, l'exercice, c'est de vous faire passer sous l'examen. It's like a vaccination. We expose your body to the disease, but it's attenuated. So when your immune system will be killing it, it won't know, is it the attenuated or is the strong? So your memory cell, your T cells will know and will fight it. C'est ça. C'est tout ce qu'on fait. On vous expose à l'examen. Quand tu arrives à l'examen, tu parles vraiment à l'aise parce que you went through the station already. Alors ça va vraiment demander que vous recevez cette lettre-là. Alors tout va se déclencher, même la manière d'étudier. OK.
Merci, Doc.
Je vais attendre qu'on voit qu'est-ce qu'on va me donner. Female doctor, I'm sorry, I'm very passionate with female doctors. Myself being female, don't take it badly. Understand, les mamans sont busy. Nous sommes busy. On a les enfants, on a les papas, on a la maison, on a le boulot, on a les in-laws, on a tout ça à manager. Alors, ça fait qu'on a peu de temps. À chaque fois que moi j'étudiais avec les hommes, c'était moi qui préparais les foufous pendant qu'eux sont en train de répéter une question. Donc, je laissais toujours la porte de la cuisine ouverte pour dire non, c'est la session, mais en train de tourner le foufou. Ça prenait un peu le temps. Eux, ils sont là. Et puis, quand tu amènes le foufou à la table, ah, docteur, tu ne sais pas préparer le foufou. Regarde, la farine sort dedans. Pendant que je faisais vite, pour qu'aussi je vienne étudier. Alors, je connais ces histoires-là. Et ceux qui ont les bébés, c'est le temps de flou. Si tu passes 2 nuits sans dormir parce que your baby have a nasal congestion, your baby, it make you not to wake up strong, not to study. So female doctors are a bit late. So you need to have a way of going forward. This COPD, let me tell you, there are people who's going to go through that gold pocket guideline and finish it by the end of this weekend. Toi, tu n'auras pas le temps. Tu vas classer ça, c'est je verrai ça. Je verrai. At the end, tout est là. Je verrai. Alors, female doctor, there is a female doctor CODOSA where I want you to drive the things. S'il faut recommencer cette présentation dans les female doctors, je le ferai encore. Si vous avez des questions, vous voyez, il n'y a que I couldn't pick up one female doctor who's talkative. That one will pass, I'm telling you. Because she is strong enough, she's trying. Elle ose, she can do. Les docteurs ne parlent pas. Elle connaît ce long des questions. Elle ne parle pas. Il n'y a pas tout ça. Nous, on sera content quand vous avez réussi. Et je vois le président ici sauter quand on lui dit 97%. Il saute comme si c'est lui qui a réussi. Il dit, wow, bien, well done, CODOSA, well done, CODOSA. Quand on dit 50%, pas 50%. You have to pass 97 and even 100%, I will be happy. So female doctor, ask question. There is a female doctor somewhere there where we catch up. Dr. Belata is there. She's always be there to repeat and to start again and to follow you up. I'm also available. Sometimes during the day, we don't answer your question. We come and answer at night. Sometimes I don't answer fast because I want your brain to go. Even if it's clear, I can see the answer is this one. I will let you talk and talk and talk. When I open my phone, 125 message. Who's asking question? CODOSA academic. I just look, where's the question? Oh, the question is over there. Let them finish themselves. It make you think. It make you think. It make you to go and search again more. That's what I want you to do. And then commencez déjà à épargner. Save money of locums. Don't eat everything because you're gonna need the whole month off. So you need to survive. You need to survive. Parce que je sais ceux qui partent et qui viennent rapidement, c'est parce qu'il n'y a rien. Je dois payer le loyer, je dois payer le cours des enfants. Start saving now. Pour que vous preniez un full month. When you go once. Please, good luck, doctor. I really empower you. These things are not difficult. We come from very far. The way we are studying in Congo and the way things are here things are easy. It's only a planning and time. So good night. We will meet again. I do not know which one I'm going to present for a meeting. And the Dr. Baka will tell me if you want me to take something out.
Thank you very much, Doc.
Good night.
Thank you.
Good night, docteur. Merci beaucoup en tout cas.
Thank you, Doc.
Je vais vous laisser
Thank you, Doc.
commencer à sortir et je vais end the meeting when only are remaining. Thank you.
Merci, docteur.
Okay.
You're welcome.
Kabreko le chaile.
Isha nakupola. Docteur Valérie.
Oui, maman Nathalie.
C'est comment le COPD? Est-ce que tu vois que tu montais les malades au Sagérien?
Tu sais, le bad qu'on vient de donner, j'ai mis ma main en l'air pour répondre, vous ne m'avez pas cité. J'avais la réponse directement.
Ah, donc toi, tu ne montais pas aux malades, c'est bon.
J'ai voulu répondre directement, mais malheureusement.
Docteur Valérie.
Ça nous donne un grand esprit, le contenu, tout ça. Quand on revient encore, on va fixer bien la matière.
OK. Il faut revenir le plus... Je ne sais pas. Prends un temps, prends le week-end où every day, finis-moi l'asthme et finis. And go in different books. You're gonna enjoy. Tu vas voir celui que tu aimes ou qui explique bien, tu vas prendre. Parce que j'essaie de faire encore la synthèse, mais go through, make your own summary. Fais déjà dans ton book là, your own summary. It will be fine.
Merci.
Et tu vas voir aussi les médicaments parce que souvent, nous, au gouvernement, on est limité. On reste là, dioline. Non. Mais quand tu vas en privé, il y a beaucoup de traitements qu'on donne. Alors, il faut connaître déjà celui-ci, voilà, celui-ci, sa catégorie, celui-ci.
Beaucoup. Et on a eu une autre vision. Donc, avec l'exposé, ça nous a beaucoup aidé. Hein? Ça nous a beaucoup aidé. Et on va encore revenir sur ça. On va lire, on va faire le résumé. Quand on va revenir encore avec les bases, on va répondre, on va bloquer, surtout bloquer.
Le docteur qui dit, na muvunja mbavu, arazolanda ba malade. Basha kukushimamia ba mingi blue bota moya naingia utafuaje? Hiyo sana inaishana naye. Unabiangalia mbele vyote binakuwa bimafemoterol, babaterol, and il y a d'autres dons, mais même pas les all. On te donne le nom commercial. Le temps que tu fouté non scientifique kule chini. Inakuwa sa flamiste. Flamiste ni nani? Kama unamwona flamiste ni nani? Ni flutikazo. So, kile kiko kinini? Flamiste. Unaanza kutafuta doktora ashikusime mamiste. Mamiste iko wapi? Haina mist. Ni flutikazo ni on ni corticosteroid. Budenozide. Ma idiko wapi? Ma di ni ma low patent corticosteroid. Alors il faut voir le nom commercial
et le nom scientifique.
Le nom scientifique. Et le nom scientifique, banaitaka kule chini kaloko. Bambe va para kile kiabo kia kinini banaweka. Tu vois un peu. Mais bon, ça va aller là, vous êtes encore relax. C'est le moment d'avoir beaucoup de physiopathes et beaucoup des histoires à lire. Lisez. Faites-vous seulement une discipline. Avant de dormir, je finis quelque chose. Avant de dormir, je finis parce que kama tu albitra napika furimbi, ile mamikanda inatoka. Mchunge mtoto. Furimbi kipiga unakuwa yulu yulu.
Inakuwa déchargé.
Ile samwe benye ndio mnaanza chokozana tena pa groupe. Pour some kitumie mbele, unitumie mbele, balanza pa kukutumia et tu te rends compte benye on la kutumia au biche. Ça c'est le moment de relax et de aller deep.
Ben, on n'a plus le temps, hein.